All right, everybody, we're going to talk about some obesity medications while we eat. This is going to be a little fast paced because we have limited time, and I'm focusing really just on pharmacotherapy for this talk. We could spend over an hour talking about obesity and pediatrics in general and lifestyle treatment options and what the current guidelines are. But for this talk, we're focusing simply on medical therapy. I have no disclosures. And we're going to review some of the pharmacotherapy mentioned in the most recent guidelines released from the AAP. I encourage anyone who sees children to read this. They're quite lengthy. It is about 75 pages of material, and only 2.5 pages of that is devoted to pharmacotherapy. So keep that in mind while we're discussing options. But it's a very wonderful article that gives us a lot of good insight into how we should be treating this ever-growing problem. So briefly, the consensus recommendations by the AAP put out earlier this year are that pediatricians can and should offer weight loss pharmacotherapy to certain patients, and that weight loss medications require the same oversight and expertise as other pediatric medications. There's currently no evidence to support weight loss medications as monotherapy for obesity, meaning all therapy should be used in conjunction with lifestyle changes, and that pediatricians and providers should provide or refer to intensive behavioral interventions for patients and families in addition to medication. There is currently insufficient evidence to recommend pharmacotherapy for the sole indication of obesity in children under 12 years. So the medications mentioned in this talk will be for 12 years and up, and in certain cases, even older than that. The consensus does say that pediatricians can consider offering weight loss pharmacotherapy to children in the 8 to 11-year-old range based on their risks, what life-threatening comorbidities they may have, and benefits versus risks of using medication in that group as an adjunct, of course, to health, behavior, and lifestyle treatment. So this is a list of just some of the obesity or medications that have an indication for weight loss or obesity that are out there. You can see it's pretty long, and there's some others that I didn't include that are strictly used in the adult world. The ones that are now in white are the only ones that have a pediatric or less than 18-year-old FDA approved indication. So we'll definitely review all of those, and then we'll briefly touch on 2 that do not have an FDA approval in our patients, but that are used off-label quite a bit. So the first medication that has been FDA approved the longest to treat obesity in children is orlistat. This medication was first approved in 1999 for adults, and then in 2003 for our children. It reversibly inhibits pancreatic and gastric lipase. So its overall mechanism of action is to block fat absorption from the gut. Its benefit is that its exposure is limited to the rest of the body. 97% of the drug is excreted in the feces, so very minimally absorbed. So a good option to use if you have a patient with any sort of renal disease or other comorbidity that they cannot take a lot of medications. It was FDA approved again in ages 12 and up in 2003. There is an over-the-counter version of orlistat that is a 60 milligram 3 times a day dose, but this is approved in adults only. The prescription strength dose of 120 milligrams 3 times a day is what is approved in our children who are over 12 and obese. It is approved to be used in conjunction with a reduced fat, low calorie diet. It's moderately effective. The research shows a modest reduction in a BMI of about 0.55. Should be kilograms per meter squared compared to 0.31 in a placebo group after 1 year. So it is a clinically significant effect, but again, a modest one at best. Orlistat is not well tolerated, and we do not use a lot of this in our practice due to the significant adverse effects. The main one being steatorrhea. Patients will have fecal spotting, soiling, profound diarrhea, and a lot of abdominal pain and cramping, and that's due to the high amount of fat in the stools. This can be minimized with a diet containing less than 30% of fat, but that requires, dietary teaching and counseling and significant intervention for these families. There's some very rare reports of hepatotoxicity with this drug, and there is some evidence that it can help reverse signs of fatty liver disease. because it reduces fat absorption, it can also reduce the absorption of fat-soluble vitamins. So that's something to be mindful of in a patient who you're already worried about their malnutrition and vitamin intake. And if they're going to be using this long-term, they do recommend adding in a vitamin supplement that contains A, D, E, and K for these patients. Moving on to metformin, and metformin is not on the FDA approved medication list, but this is a medicine widely used by adult and pediatric medicine for multiple indications, so I wanted to go through it and touch on it a bit. Metformin has been around for many years. It is a biguanide anti-diabetic agent, and it has multiple mechanisms that it helps the body for both diabetes, but also other positive metabolic effects. Its main mechanism of action is that it suppresses gluconeogenesis from the liver, but it also assists with insulin sensitivity by making the body more sensitive to insulin and increasing glucose uptake at the level of the adipose tissue and the skeletal muscle. It also has the effect of decreasing glucose uptake from the intestine and increasing glucagon-like peptide 1 secretion and its effects. So multiple ways that this helps our patients with diabetes, which again is the main reason we use this medication. It is FDA approved in pediatrics, but for indication of type 2 diabetes in children age 10 and over only. Some of the off-label uses in pediatrics that you'll see our patients take this for is polycystic ovarian syndrome or pre-diabetes. It's also indicated in adults to prevent weight gain with the use of atypical antipsychotics. So a lot of psychiatry colleagues will put patients on metformin in hopes to prevent some of their significant weight gain. I do want to note there is no FDA approved indication in any age group for weight loss. Effectiveness, we have looked at this a good bit of using it for obesity and weight loss purposes. They did a meta-analysis in 2020 which showed less than 5% weight reduction when used in adjunct to lifestyle changes in adults. So that's about 1 BMI unit improvement. And then in 2021, they looked at this in children in a small study of only 100 children ages 6 to 12. So this is younger than our typical age group. Again, revealed about a 1 BMI unit reduction. And this is using maximum dose of 1,000 milligrams twice a day for 6 months in conjunction with lifestyle changes. They did not find any benefit of continuing therapy beyond 6 months. Adverse effects of metformin, again, are pretty significant GI effects. More than 10% of your patients are going to have either cramping, sometimes nausea, vomiting. Most of them will complain of diarrhea, increased flatulence, and abdominal cramping and distension. It is a dose-dependent effect, so we will often start them out on a quarter of the full dose and increase every 1 to 2 weeks as they tolerate it. It does help ameliorate the effect if they take it with food or if you use an extended release formulation. Regardless, though, some patients are just not able to tolerate the GI side effects of metformin. It's also of note a very large pill, so if you have a younger child that has difficulty swallowing medications by mouth, the pill is very large and they may not be able to swallow it. And of course, if you're using an extended release formulation, that is not something that you can cut or crush. 7% of patients with long-term use, and this is greater than 2 years use, will develop vitamin B12 deficiency because metformin impairs vitamin B12 absorption from the gut. And so it's important to note that if you're using this in a patient for long-term, that you do monitor their vitamin B12 levels. A small percentage of patients will have headache, dizziness, and chills, although that's less common, and there are reports of lactic acidosis in children taking this medicine. Okay, so moving on to phentermine, and this is one of our FDA-approved medications. So phentermine is a stimulant medication. It is a central norepinephrine uptake inhibitor. It non-selectively inhibits serotonin and dopamine reuptake as well, and the combined effect of these inhibits the appetite. Because it's a stimulant, it's going to increase your sympathetic activity and your catecholamine transmission. Because of its chemical structure being a stimulant, and chemically related to amphetamines, it is a Schedule IV controlled substance. It is FDA approved in ages 16 and over for short-term use for cycles of up to 12 weeks only as an adjunct to diet and exercise in patients who cannot take preferred agents, which would be non-stimulant medications, and who have a BMI equivalent to greater than 30. kilograms per meter square, or patients with a BMI greater than 27 and at least one weight-associated comorbidity. So that's dyslipidemia, diabetes, high blood pressure. I would argue PCOS is included in that list. The specific doses approved in pediatrics are either the short-release form, 8 milligrams 3 times a day, taken about an hour before a meal, or a once-daily 37.5 milligram extended-release tablet taken in the morning. Phentermine is effective. The graph that you have there is very old. This is the original study of phentermine in adults from 1968, but I wanted to include it because it's profound. It is effective. The original study showed about a 10% weight loss in adult patients. And the interesting fact that they found is this weight loss was significant in patients who took both continuous phentermine and who alternated on and off cycles of phentermine, hence the approval for it to be taken in 3-month courses at a time. In 2021, they did look at this study in adolescents, and they found a 4.1% reduction in BMI and an average of 3.2 kilogram reduction in weight at 6 months with phentermine and lifestyle modifications compared to the control group with lifestyle modifications only. And then in 2022, they found that 70% of adolescents taking phentermine have at least 5% weight reduction over 10 months. Again, this is cycling the medication on and off in 3-month intervals. Adverse effects, because this is a stimulant, this is going to have effects very similar to the medications that we often use for ADHD in children, can cause hypertension, tachycardia, and palpitations. A lot of patients will report dry mouth. It will affect sleep. And so we have to tell patients who are on the short form that they may have poor sleep onset at night. And if they are on the long release form, to take it early in the morning. If they sleep in that day, they should not take it. It can cause restlessness, irritability, and increased anxiety as well. Some patients will report tremor or headache when first starting. There are rare reports of interstitial nephritis and pulmonary hypertension, but that is a warning that comes with this medicine. It is contraindicated in any of our patients that have hypertension, who are on a stimulant already, who have any cardiovascular disease or hyperthyroidism. And so you have to think about what proportion of our patients with obesity have one of these comorbidities. A lot of them already have hypertension. So this is something to be mindful of when you're counseling on the medical options for your patient. Topiramate. Topiramate is not an FDA-approved medicine for weight loss in pediatrics, but I wanted to touch on it because the next medication includes topiramate, so it's pertinent. Topiramate is a carbonic anhydrase inhibitor. It antagonizes glutamate receptors, and it has a central effect on reducing appetite at the level of the hypothalamus. That is more of a side effect for this medication. This medicine is used in pediatric patients ages 2 and up for seizure disorders and also for migraine prevention. Those are the 2 FDA-approved indications for children for topiramate. There is no FDA approval for weight loss when used as monotherapy alone, though this is very commonly used off-label now in the adult population for weight loss. It is a pretty effective medication for weight loss, up to a 5%, really, on average 2 to 4.9% reduction with a 75 milligram daily dose of topiramate for 6 months in children ages 12 and up. It does have some significant adverse effects. Over half of patients taking this can experience a decrease in their serum bicarbonate at the seizure treatment doses. Now, often the doses required for seizure treatment are different and can be higher than what is used for weight loss, but that's important to know when you're performing laboratory monitoring on these patients, and especially if they have any comorbid kidney disease. Over 10% will also have abdominal pain, anorexia, which is one of the effects we're aiming for, and nausea. A large proportion as well will have fatigue, dizziness, and memory impairment, often described by patients as a brain fog or just a difficulty with focus and paying attention. They'll have increased daytime drowsiness and often paresthesias described as numbness or tingling of the fingers and toes. A small proportion, less than 10%, reported learning impairment in school, psychomotor impairment, nervousness, and vertigo as well. So the reason I wanted to touch on topiramate is one of the medications we do have available to us now in pediatrics is a combination pill that contains both phentermine and topiramate. It has extended release formulations of both medications, so it is given once a day. So it has a combined stimulant and central appetite suppressive effect. Because of the phentermine component, it is a scheduled for controlled substance medication. It was approved in June of 2022 for chronic weight management in pediatric patients 12 and up who are obese, defined as a BMI greater than the 95th percentile, along with diet and increased activity. The benefits of using this combined medication is it allows you to use lower doses of both phentermine and topiramate to get the same weight loss effect as you would using either drug as monotherapy at higher doses. Dosing starts at a combination of 3.75 milligrams of phentermine and 23 of topiramate once a day for 14 days. And then if the patient is tolerating this well, you increase to 7.5 milligrams of phentermine and 46 of topiramate once a day. After the first 12 weeks of therapy on the moderate dose, you're to recheck the BMI and assess for improvement. If they've had at least 3% or more reduction in their BMI from baseline, then you continue the moderate dose. If their BMI has not improved at least 3% from baseline after 12 weeks, you can increase to a higher dose of 11.25 of phentermine and then to a maximum of 15 milligrams of phentermine, 92 milligrams topiramate once a day. If the patient has been on the highest dose for 12 weeks, you should reassess their BMI, and if it has improved 5% or greater, then you can continue the high dose. If it is reduced by less than 5%, it is deemed they are not a responder to this medication, and you should discontinue therapy at that time. It is a pretty effective medication. Low dose use, so this is the moderate dose of the 7.5 milligrams of phentermine, saw a 4.8% reduction, and then the moderate dose saw a 7.1% reduction in BMI versus a 3.3% gain in BMI in the placebo group. So definitely more effective than the other medications we've reviewed so far. When treatment was continued for 56 weeks, you can see that some patients achieved up to a 20% reduction in their BMI. So pretty significant impact that this medication has made. And of note, with this one, you do not have to cycle on and off as you do with phentermine monotherapy. Moving on to liraglutide. Liraglutide is a glucagon-like peptide 1 receptor agonist. It is a daily subcutaneous injection, and it is 95% similar to RN8 GLP-1 secreted by our own bodies. GLP-1 is released in response to food intake, has multiple effects, but they include slowing gastric emptying, has a direct effect on the hypothalamus to signal satiety and reduce the hunger signals. It increases your insulin secretion and sensitivity, and it reduces your hepatic glucose production. So again, multiple metabolic benefits from this class of medication. We know now from adult literature that there's also increased benefit of cardioprotection and improved cardiac function in patients on GLP-1 receptor agonist therapy, particularly those with diabetes. So it has benefits for our diabetic and non-diabetic patients. Liraglutide was approved for children greater than 12 in December 2020. They must have a BMI greater than the 95th percentile or equivalent to adult BMI of 30, and they must weigh at least 60 kilograms. And again, used adjunct to reduce calorie diet and increase physical activity. Dose escalation is required with this medication, as you'll see on the next slide with the side effects, starting with 0.6 milligrams a day, increasing by 0.6 once a week to a maximum dose of 3 milligrams daily. On a 56-week study of maximum dose, so that's 3 milligrams a day of liraglutide in pediatrics, it revealed a BMI Z-score reduction of 0.23 versus 0 with placebo. And so now that is the Z-score, the standard deviation, not absolute BMI reduction. And the estimated mean relative change in body weight percent from baseline of minus 2.65 for the treated group versus an increase in relative body weight change of 2.37 for the placebo group. In the adult studies, we do not have sustained weight loss studies in pediatrics at this time. They are ongoing, but in the adult literature, we do see that with continued use of liraglutide, there is sustained weight loss after 3 years of continued treatment. Other benefits that have been found of using liraglutide in our adult population that we can extrapolate to our teenagers is reduce waist circumference by 3.2 inches versus 1.6 in the placebo group. Significant reduction of cardiovascular events in adults taking this medication that have type 2 diabetes. We also see improvements in lipid profiles and improvements in insulin sensitivity when improved hemoglobin A1C in patients with diabetes. The adverse effects, and this is specific to adolescents, the incidence is a little bit different in the adult population. Over a third of patients on liraglutide will have nausea and vomiting. About a quarter of them will have diarrhea, so again, significant GI effects. There is a 15% risk of hypoglycemia that is considered symptomatic, but mild, meaning it does not require medical intervention. There is, of course, increased risk of hypoglycemia if your patient is also on medication for diabetes. 12% will have stomach pain and inflammation, and then again, 5% constipation, dyspepsia, and reflux. A lot of patients report up to 10% reported dizziness, fatigue, and increased depression when they started the medication, and there are a few case reports of suicidal ideation in teenagers starting liraglutide therapy. And again, in adults, a little bit higher risk of pancreatitis, but less than 1% risk in the pediatric population. There is a black box warning on all GLP-1 medications for a risk of thyroid C-cell tumors, so you cannot use any of these medications in patients that have a family or a personal history of MEN2 syndrome or a family history of medullary thyroid carcinoma. Semaglutide is a newer variant of a GLP-1 receptor agonist. The benefits of semaglutide is it is a once-a-week injection versus once a day. It's been approved since January of this year, again for 12 and up. Obese patients, in addition to lifestyle changes. Again, this is medication that requires dose escalation. This comes in a single-use auto-injector pen device that's patient user-friendly, and it has a pretty specific dose escalation schedule. Due to the GI side effects of this medication, it does say if it's not tolerated, you can resume the last tolerated dose for another 4 weeks before attempting to titrate up. In the original study, there was a significant proportion of patients that could not tolerate the maximum dose, but they did find they had benefit to continuing the lowest tolerated dose, even if they were unable to titrate all the way up to the 2.4 milligram dose. As you can see, after 65 weeks of use in our patient population, there was a significant difference in both percentage change of BMI and reduction of body weight of greater than 5%. So I would argue so far this is our most effective weight loss medication in this population. Adverse effects, again, there, diarrhea, nausea, vomiting, and constipation, as with this class of medicine, some headaches and nasopharyngitis as well. Interestingly enough, about 3% of teenagers using this did report some hair loss. So that's important to note. And there are rare reports of acute necrotizing pancreatitis and interstitial nephritis. Again, same black box warning as liraglutide. Very briefly, I just wanted to mention this drug to you. This is not something that outside of endocrinology or genetics that you will probably prescribe, but there is a new medication called setmelanotide, which is a once daily injection that's FDA approved for weight management in adults and children over 6 who have a specific type of monogenic or syndromic obesity due to certain genetic defects listed here. And this has to be determined by an FDA-approved genetic test that shows a mutation in one of these genes, a pathogenic mutation in one of these genes, or they must have a clinical diagnosis of Bardet-Biedl syndrome. Setmelanotide works through the MC4R pathway, which is important for regulation of hunger and satiety in the brain, and it is thought in these conditions that the MC4R signaling is interrupted. And so reduced activity at the MC4 receptor results in hyperphagia, decreased energy expenditure, and weight gain. And setmelanotide increases signaling at this receptor to increase satiety signals, reduce hunger, and decrease food intake. It's extremely effective in the populations that it's approved for. You can see there's significant weight loss over the course of 3 months of using this medication, rapid weight gain during a withdrawal period, and then subsequent weight loss when the medication is restarted. But again, this is available only to patients with those proven genetic anomalies. Lisdexamfetamine. This does not have an FDA approval for weight loss reduction. I wanted to mention it though because it is often used in adolescents, particularly with binge eating disorder, because it does have an FDA approval for binge eating disorder in our adult population. In pediatrics, it is used for ADHD in those ages 6 and over. It again is a stimulant class medication. We're all very familiar with how these medications work for our patients with ADHD. It does seem to have a very good effect on appetite. In a study where they did a 2-year open label study where it was being used for ADHD, they found a BMI Z-score reduction of 0.1 and a BMI reduction of 0.86 kilograms per meter square when compared to placebo. And the graph there is from a case report of a patient where it was used off-label for obesity, and you can see that this patient had a pretty profound weight loss effect after the lisdexamfetamine was started. So in summary, we have 6 FDA-approved medications for weight loss in pediatric patients, all for ages 12 and up, except phentermine, which is ages 16 and up, and setmelanotide, which is 6 and up, but only for proven genetic diagnoses. There are no FDA-approved pharmacotherapy options for obese children under age 12. So in summary, our pharmacotherapy is a portion of our comprehensive obesity treatment. Pharmacotherapy should be integrated as part of weight management strategies, including behavior and lifestyle treatment. These are the references. I'll pull up the chat real quick because I think we just saw a question. Okay, yes. Are any of these drugs effective in Prader-Willi syndrome? So yes, so far actually in Prader-Willi syndrome, we have found that liraglutide has been fairly effective in those patients, and those patients are at high risk of developing type 2 diabetes as well. And so we can see both benefit in their glucose control and their weight loss in patients with Prader-Willi. Unfortunately, we have not come up with a medication such as setmelanotide that can really target the problem in Prader-Willi, which is just lack of satiety signaling in the brain and hyperphagia. But so far, GLP-1 receptor agonists are the most effective medication in that group of patients. Do you have any other questions? Okay. All right. Well, thank everyone for listening. Yes, I think we can make this shareable. Yeah. Thank you. I know that was rushed, but if you have any questions, please just send me an email. I'm happy to talk about weight loss treatment in our kids. So thanks. Let's see. And have a great, oh, sorry, one more question. Is it useful to measure fasting insulin levels in pre-diabetics? So in general, no. The AAP does not recommend measuring fasting insulin levels in obese children, mostly because the level varies throughout the day, and you can typically see symptoms of insulin resistance on exam, with, such as acanthosis, without having to check an insulin level. I have found it useful in some patients who seem to not take seriously the degree of their obesity or not understand how dangerous it is. But when you come to them with a lab value that shows how high their insulin level is, sometimes that can be eye-opening for parents to understand, hey, this is a big deal, this is serious. But in general, for most patients, no, we do not recommend measuring fasting insulin levels. Okay. All right. Thanks, everybody. Have a wonderful day.